You probably don't hear that word very often these days, so I hope I'm going to be able to give you quite a lot of information about cemented arthroplasty. I was asked to talk about our experience with Exeter Hip beyond 20 years. Well, we can easily do that because the Exeter Hip was developed in 1969. Can we move along? Thank you. At the School of Engineering at the Old Orthopedic Hospital in Exeter by Professor Ling. And the hip was first used in November 1970. So our experience now with the Exeter hip is to 44 years. Now, what you see on this graph, this is from the National Joint Register in the UK out to 2013, and you see that cementless hips increased rapidly up to about 2010, but are now dropping off, while cemented are going up a little bit, as well as the hybrids. Now, everyone says, well, cementless is much more common than cemented in the UK. But if we look at stems, all these hybrids have cemented stems. So actually, we have 53.5% cemented stems and 45.5% cementless stems. So cemented stems in the UK are still much more common. And then we go back to a hip which has been around for 44 years. And we see that the Exeter hip is still growing while most of the other cemented hips, and they're virtually all collarless polished tapers, are dropping off. So Exeter is hitting nearly 70% of the market in the UK. And in fact, believe it or not, in terms of numbers, it is the commonest used hip replacement in the world and one of the most successful. And it's the commonest used despite hip replacements in general moving to cementless devices. And on all national joint registers, cemented hips continue to match and mostly outperform hybrids, cementless, and resurfacing hip replacements. So this was the Exeter hip that you see on the left, which was used between 1970 and 1975. And we did 433 of those hips up till December 1975. And here you see the breakdown. It includes hips with previous surgery and, in fact, revisions of other hips. So it was a consecutive 433 hips of all diagnoses. We'd lost 6.5% to follow-up. The cementing technique in those days was terrible. There was no cleaning or washing. The cement was merely pushed into the dirty, bloody canal with thumbs. And despite that, at the end of 2003, sadly the numbers were getting pretty small, which is hardly surprising after 30 years. But we only had 25 living patients with 30 hips. But interestingly, none of those 30 hips had had the stems revised for aseptic loosening. That's between 28 and 33 years post-op. Now, before going on with that, sadly, the image of cement has become this, building cement. Actually, many of you may not know this, but this is cement. This is bone cement. Fiber optic cables, contact lenses, even intraocular lenses. So this material is very well accepted by the body. And in fact, this is the structure of PMMA. It's made of carbon, hydrogen, and oxygen. So in fact, cemented fixation is polymer fixation. It's a polymer, it's an acrylic, and it's truly biological fixation, carbon, hydrogen, and oxygen. Now I'll just go back to that initial series, and having just told you what I've told you, it's not surprising that cement can be accepted and stay in the body for a long, long time. And the loosening rate in that original series, that 433 cases for the stem, is 3.5% at 33 years. Even the socket is not too bad at less than 10%. So these cases did very well despite poor technique. And here you see the survivorship curve. And it's 93.5% at 33 years for aseptic stem loosening. Endpoint revision for aseptic cup loosening is 72% at 33 years. And just to show you a couple of x-rays, this is a question I'm asked extremely often. What happens as the medullary canal gets bigger and the cortex gets thinner? Don't these hips come loose? Well, I don't see why that should be any different whether you had a cemented or cementless stem, but the answer is they don't. And here you see a lady aged 58, 10 years later, 68, there she is 78, and here she is 88. Well, firstly, despite her bone getting thinner, look how well the proximal femur is maintained. Her cortices have got very thin compared to that, and yet the hip has not loosened. Here's a lady who was 30 at the time of her operation. She was a nurse. She went back to full-time work. She loosened her socket after 13 years, but look at the quality of the proximal femur. Here she is at 26 years. The stem has not been changed at any stage. And here she is at 33 years. Again, look at the quality of the bone in the proximal femur, and I'll discuss that in just a moment. This was a man who weighed well over 200 pounds. He was a carpenter. Here's his x-ray 6 months post-surgery, 12 years, 22 years, and 30 years. Again, look at the quality of bone in the proximal femur. Right, let's move along to 1988. There were a couple of other hips used, Exeter hips, with the same design used in the interim, but I haven't got time to go into those details. But coming to the one which was introduced in 1988, which had a modular head and used until the present. We looked at the first 325 cases, and the survivorship at 16 years was 100% for aseptic stem loosening. And this is now with good cementing technique. Now, what is of importance, this is not a selected series. This is every single hip that comes through Exeter. No surgeon in Exeter does an uncemented hip replacement, uncemented stem in a primary. I've done over 5,000 hip replacements. I have never placed a cementless stem in a primary hip, and my patients age from 14 to over 100. So our experience with that present stem extends now till 26 years. And just before I give you the 20-year results of that, I'm going to just tell you a little bit about our young patients. We looked at a series of patients aged 50 or less with a 10 to 17-year follow-up. As I mentioned, it doesn't matter how old the patient is, what the pathology is, what the bone quality is, or femoral deformity. In Exeter, we only do cemented stems. And we do them in complex cases like this. We do a subtrochanteric osteotomy, we fix the osteotomy, and we cement a stem in. Here's a lady with Gaucher's disease. You see the Gaucher's lesions here. Cemented hip replacement, post-op, 14 years down the line and still looking extremely satisfactory, and 8 years on the other side. So just to show you that we did it in a lot of very young patients. So we had 130 hips, 130 hips in 107 patients. 6 patients with 7 hips had died. None were lost to follow-up. Average age at surgery was 42 years, and there were no exclusions. We had 9 loose cups, or 7% failure rate by 16 years, but no stem had been changed for aseptic loosening in these 130 cases, average age 42. Cemented hips, as long as you do the right type, does well in patients of all ages. And this is the survivorship curve with any reoperation in these patients under the age of 50 at 16 years was 85%. Revision for aseptic cup loosening, and these were all cemented cups, 89%, but there were no revisions of the stem. So survivorship was 100%, or no revisions for aseptic stem loosening. As I said, contemporary cementing was done with all these cases since 1988. This year we did a 20-year minimum follow-up on these cases, 1,050 consecutive hips with a follow-up of 20 to 25 years. Here you see the the breakdown. We were able to review 223 hips. We had 192 radiographs, and 726 of patients had died. So here you see the average age at surgery was 67.8. You see quite even very young patients are done. The average age of the survivors was 56 years. The average age of those that had died, 72. And the average age of those revised was 58. And you see the indications for surgery were all indications. A large majority primary OA, but there were protrusios, rheumatoids, avillus necrosis, failed osteotomies, etc., etc. 86 of the patients had previous surgery. Here are the revisions in those 1,050 cases. The cup gives us the most trouble. 67 of those failed, but only 2 stems over that length of follow-up needed revision for aseptic loosening. And one of those happened to be that lady with Gaucher's disease. So the survivorship at 23 years with regard to stem revision for aseptic loosening is 99.2%. The stem all causes, 96.7%, and the hip all causes, 81%. So here's a breakdown just showing the Kaplan-Meier survivorship curves, and really the most impressive part of it really is the stem. So although the sockets did well, I'm not trying to give you a special message about the socket. If you do a good job, they do well, but the stem does behave quite remarkably. So what is the ideal stem? Well, an ideal stem should give you no movement at the cement bone interface or metal bone interface if you use an uncemented stem, avoiding loosening in the long term. Load transmission should be through the metaphysis and proximal diaphysis to preserve proximal bone stock. It's quite nice to obviously have a stem that will attenuate peak stresses to avoid shock loading and thereby reduce component wear. You want perfect position totally under your control, no pain, in particular thigh pain, and ease of revision. So here, point 1, movement at the cement bone interface. This was a study done in Oxford, RSA study, and you see that the stem migrates distally in the cement in a slowing pattern up to about 1.2, 1.6 millimeters, but there is no movement at the cement bone interface. And this was also shown by an RSA study in Sweden. Proximal load transmission. Well, the eccentric taper here allows load to transmit here. As the component subsides 1 or 2 millimeters, the cement here gets displaced more than the cement anywhere else. So it really loads the bone in this area, and in fact, the stem moves slightly into valgus as it subsides. What about bone cement? Is it a shock absorber? Well, here you see 2 identical bars of bone cement exposed to the same load, which was only 8 kilograms, for the same length of time. So what's the difference between these 2 specimens? Well, this was done at room temperature, and this was done at body temperature. So cement is a very different material at 37 degrees compared to room temperature. This was a paper published in the JBS some years ago, a study done in Australia using navigation, and they clearly showed, with regard to component positioning, it was much easier to put cemented components where you wanted them to be than uncemented components, which just stopped when they got to the position they wanted to stop at. There was total control with cemented components. And finally, second to last, what about patient satisfaction? Well, Exeter's probably got the highest percentage of cemented hip replacements compared to hybrids, and in fact, we don't do any uncemented at all. 90% of the hip replacements we do are cemented. And here are the results from the National Joint Registry of all units in the UK doing hip replacements. The average improvement in Oxford hip score was about 20. There's one outlier there to the good side, and I'm very pleased to say that that is Exeter. Now maybe, you can't be sure, but maybe it's because all our patients have cemented hip replacements. And finally, in the young, one must consider ease of revision surgery. This stem is modular at the stem cement interface, And cement revision hip replacement, both on the acetabular side and the femoral side, are very easy to do, and I'm going to be talking about those tomorrow. So what is the ideal stem? Well, I'd have to put it to you, it's highly polished, it's double taper, it doesn't have a collar, and it works within a low modulus material, in other words, bone cement. Thank you very much for your attention.